Are there any other technologies besides CTCs that people are looking at in terms of a liquid biomarker, liquid biopsy, if you will?
This is a huge area right now of early biotechnology companies and large companies looking at this. Circulating cell-free DNA is something that is in the works. It's not quite tuned to the point where we can detect the splice variant because that's a splicing variant and not so much a DNA based mutation. Circulating tumor cells remain commercially available, but mostly for enumeration. So again, the V7 would be the first qualitative assessment of circulating tumor cells that would be useful. And then there are a whole number of other companies out there that are seeking to exploit the genomics or the other protein expression in circulating tumor cells. But like I said, some people don't have circulating tumor cells.
Right. And I think it's important that everybody remember this is just one of many variants that can happen at, in the AR. So Judd, you've got a multidisciplinary, a very highly functioning multidisciplinary clinic at Duke. So you've got, really, you're representing the urology side. You've got Andy and Dan over there on the GU side. So how do you think this is going, assuming that this comes to fruition and this is something that is going to be commercially available, hopefully, how do you think that this is going to impact your particular practice, your multidisciplinary clinic? What's the importance of this long term?
Well, that's a great question. I think that certainly this is maybe one of the first examples of truly personalized medicine that could come to the forefront in castrate-resistant prostate cancer. Of course, as a urologist, thinking historically, I think a lot of urologists might be freaked out about this. It's hardcore molecular biology. How are they going to remember this? Is it something that's going to affect their practice? But we've known about resistance to hormonal therapy since Huggins' time in the 40s, and then I can remember when we were in training, the flutamide withdrawal syndrome came out, and everyone was hot about AR mutations, but I guess that was a little bit ahead of its time because we couldn't really figure out how to apply that clinically. And I guess putting my skeptic's hat on, is this going to be flutamide withdrawal number 2, where it was a cool molecular concept that never really came to pass? Final point for us as urologists, and we're going to talk about this later, is that we're, as urologists, we're mostly in the space of M0 CRPC. And one of the questions that I was going to ask you guys is that, like in an M0 CRPC, can you actually measure circulating tumor cells? And if we start pulling the trigger for the oral agents even earlier, how will this come into play? So I'm answering more questions than I'm answering. But again, in the multidisciplinary clinic at Duke, we're very proud of the effort, but sometimes we still have challenges in the pass-off between when is it a urology patient and then when does it transition to medical oncology. We try to play well in the sandbox, but that's one of the questions we have.
Now, Mike, we were talking earlier before we started about a trial that's currently underway where it is a novel molecule, galaterone, and as part of this trial, there is the co-development of the companion diagnostic looking for the splice variant. So I know you guys are involved in that trial. Give us some update a little bit in terms of what you've seen so far.
So very early, we may have just referred the first patient or just started the trial. As we noted, there's probably only been about 40 patients, I think, or 50 patients. So from our personal experience, we don't have a lot of experience with the drug, but I think the drug is potentially, galaterone is very unique in the fact that it has probably several mechanisms of action with inhibition of a receptor and maybe a weak lyase inhibitor as well. So I think it potentially provides some opportunity for us, as Joel said, to provide personalized treatment. I think the results are pending, but it is exciting. We wouldn't be having this conversation 3 or 4 years ago with prostate cancer. And 7 or 8 years ago, none of these conversations we're about to have would actually have occurred. It's hormones and a receptor blocker, and that's it. And now we have a variety of different things. So I think this trial is very exciting, but have to wait.
Yeah, I mean, I think if you would have, especially for urologists of our generation, if you would have told me 5 or 6 years ago that as a practicing urologist in independent practice, in community practice, if you would have told me that I had to have a working knowledge of the androgen receptor in order to manage my patients for prostate cancer, I would have said you were completely out of your mind. There's no way. I think it's going to be critical for all urologists, whether you are dealing with whether you're involved in a multidisciplinary clinic, whether you're in independent practice, small practice, large practice. I think to better take care of these advancing prostate cancer patients is going to be critical.